Good day, everyone. So I'm Dr. Bataclan again, and this time I will be discussing the different anti-tuberculosis medications. So that would be the entire scope. So it will be limited to the medications available locally. Okay, so in the Philippines, okay, it accounted of a very high proportion of global tuberculosis cases. About more than a tenth of total global tuberculosis cases are found in our country, and more than half a million of new cases are found annually. And it still has a significant cause of morbidity and especially mortality, because every hour, 4 Filipinos die of pulmonary tuberculosis or extrapulmonary tuberculosis and its related complications. So, as you can see here, even with the availability of anti-TB medications, there's still a steady increase of the case detection rates um, of tuberculosis. Although it is also accompanied with increased TB treatment coverage in the country. There was a slight drop, as you can see here in 2020, but this is largely due to the pandemic. So the case detection and the management of these tuberculosis cases were decreased, no, because we are more focused on COVID-19 during that time. But eventually, that we have adjusted, no, to the new normal. So again, the treatment coverage and the detection rate is now slowly again increasing. So we can say that there's a multitude of risk factors that can cause pulmonary tuberculosis. While um, understandably, tuberculosis is an endemic infectious disease in our country, you can still avoid having pulmonary tuberculosis. Okay, there could be host characteristics. So, extremes of ages would definitely be susceptible for tuberculosis because of a relatively undeveloped immune system for the younger age group and a depressed immune response among older patients. For gender, they say it's more susceptible among males because usually it's the males that are located in crowded places. And I mentioned immune status. Malnutrition, which still has a high prevalence in our country, definitely affects the immune system of the host. Therefore, it can uh, be more susceptible in getting tuberculosis, and presence of other comorbidities such as diabetes, which also dampens the immune system of an individual. Close proximity and the longer duration of contact also has a big factor, no, for the host. So there would be a multitude of cases that in one household, there could be more than one individual who has a clinical manifestation of an active tuberculosis. Um, since most of the Filipinos are in the urban areas, so crowding, poor ventilation are very, very important factors that would also contribute to the susceptibility and increased risk of having pulmonary tuberculosis. Adding to that, some factors that would decrease your protective mechanism in your lungs, which is the primary route of entry of tuberculosis, such as smoking, alcohol use, and even occupational risk. So in factories or in manufacturing areas in which there's smoke or exposure to noxious odors that would weaken the structural and the functional integrity of the respiratory tract. And so it's an multitude of factors that can lead to the development of pulmonary tuberculosis in our setting, in our locality. So I won't go into the clinical manifestations or the laboratory findings because that would be discussed in a different subject. So, but what is important is that tuberculosis has a multitude of options in terms of treatment, but still, for the longest time, these are the first-line medications that are given for Mycobacterium tuberculosis. So, four of these are available in oral form: the isoniazid, rifampicin, pyrazinamide, and ethambutol. Streptomycin is a parenteral antibiotic, and we will discuss their individual properties after this slide. So you can see here, so those are the letter codes of those anti-TB drugs, and then there's the dosage is usually computed, no, in terms of milligram per kilogram per day, and there's some maximum dose as you can see here in the table. So you can review the clinical practice guidelines in the management of tuberculosis, and this is a local guidelines created by various organizations under the guidance of the Department of Health. So there are treatment categories that the patient can be labeled into, no, depending on the clinical scenario of that individual. So, for example, if the patient is newly diagnosed with pulmonary TB, the patient has the symptoms like cough of more than 2 weeks with weight loss, fever, difficulty of breathing, and then there's a radiographic and um, microbiologic evidence of tuberculosis, so either sputum AFP or gene expert. So, and the patient did not was not diagnosed before tuberculosis, so the patient would be new pulmonary tuberculosis. Miliary TB, meanwhile, is an extrapulmonary form of TB that is usually affects the liver. And other extrapulmonary tuberculosis, or the EPTB, except the neurologic and the musculoskeletal tuberculosis, also belongs in category 1. And as you can see here, the regimen would be 2 months of isoniazid, rifampicin, pyrazinamide, and ethambutol. That's a 2-HRZE. And then 4 months of maintenance treatment of isoniazid and rifampicin. Category 1A now would be the other extrapulmonary TBs. Still, the first 2 months, which is called the intensive treatment, would be the same as category 1, but a longer maintenance phase of 10 months of isoniazid and rifampicin, because most of these drugs have difficult penetration in the joints and difficulty in passing through the blood-brain barrier, which is very important in treating any kind of central nervous system infections. Category 2, meanwhile, is retreatment of rifampicin-susceptible pulmonary tuberculosis, and again, the other extrapulmonary tuberculosis. So it should be a retreatment. So that means that the patient had a previous history of PTB treatment. Either the patient completed it and developed, again, new symptoms and was found to be microbiologically proven to have the presence of the infection, or the patient may have failed in continuing or completing the treatment of pulmonary tuberculosis. So as you can see here, it's 2 months again of the intensive treatment plus streptomycin, and then 1 month of isoniazid, rifampicin, pyrazinamide, and ethambutol, and then the 5 months of maintenance phase, which is isoniazid, rifampicin, and ethambutol. For 2A, again, that's the more unique extrapulmonary TB, the central nervous system, and the musculoskeletal TBs, wherein again there's a longer maintenance phase of 9 months of isoniazid, rifampicin, and ethambutol. So again, here just enumerating the specific types of extrapulmonary TBs. So, and all of them have a strong recommendation, varying from low to high quality evidence, the highest of which would be for the CNS central nervous system tuberculosis infections like TB meningitis. So for treatment category, so yeah, again, there should be, so for those not taken anti-TB medications, or they may have been taken before but only for less than 4 weeks, that's new cases. But if you took the medication at least a month, would be called a retreatment, and there would be these various classifications, such as relapse, meaning they were already declared cured at the end of the treatment and again had a recurrent episode of pulmonary tuberculosis. There's also treatment after failure, meaning um, the patient completed the course of pulmonary treatment, but still, there's still a microbial evidence of pulmonary tuberculosis. Treatment after loss to follow-up, so this one definitely did not completed the anti-TB medication and it was lost to follow-up. And then previous treatment outcome unknown. So again, there's a certain overlap with the treatment after loss to follow-up. And there are also other patients that may not fit, in the categories mentioned. So we will go first with the first line medication. So the first one would be isoniazid, which is a anti-TB drug. So it's an antibiotic that primarily targets the synthesis of mycolic acids, which are essential components of the cell wall of the Mycobacterium tuberculosis. It is a prodrug that is activated by CAT-G, which is a mycobacterial catalase peroxidase. The activated form of isoniazid forms a covalent complex with an acyl carrier protein and KASA, which is a beta ketoacyl carrier protein synthetase, which blocks the mycolic acid synthesis. So therefore, it affects the integrity of the mycobacterium cell wall. So as you can see here, so it's a probe drug, and then inside the bacteria, it's activated, and it exerts now its activity in inhibiting the cell wall production or maintenance of the integrity of the bacterial cell wall. So it is well absorbed from the gastrointestinal tract after oral administration. Its peak plasma concentration is reached within 1 to 2 hours. It has a wide distribution throughout the body, and it can also cross the blood-brain barrier. In terms of metabolism, this undergoes primarily acetylation and dehydrogenation in the liver. So this is very important, as I would discuss later. But the metabolites is primarily excreted in the kidneys, in the urine. The half-life of the isoniazid varies depending on the acetylator phenotype. So there are two main kinds of individuals that would have metabolism of isoniazid, what we call the rapid acetylators. So therefore, the half-life among these, since there is a quicker or more active acetylation process, the half-life is just 1 to 3 hours. While for those slow acetylators, meaning their acetylation is not that rapid as compared to the rapid acetylators, their half-life is around 6 to 10 hours. So this is a bactericidal medication, and there's also resistance to this drug with mutations resulting in the overexpression of the gene INHA encoding an NADH-dependent acyl carrier protein reductase. Resistance can also be due to mutation or deletion of the CAT-G gene. There's also mutations resulting in the overexpression of HPC, which is a gene involved in the protection of the cell from oxidative stress, and mutations in the KASA. So overproducers of the INHA can produce low-level resistance and cross-resistance to ethionamide, which is another anti-TB drug I will discuss later. CAT-G mutation, meanwhile, expresses high-level isoniazid resistance, but there's no cross-resistance with ethionamide. There are also significant drug-drug interactions with isoniazid. Aluminum hydroxide, for example, which is an antacid, it can inhibit or delay an isoniazid absorption and lower serum concentration. So especially for those with peptic ulcer disease and recurrent gastrointestinal complaints, would taking antacids, isoniazid might be less effective because it inhibits or it delays the absorption of the drug. Anticonvulsants such as phenytoin can inhibit also the metabolism, leading to increased blood levels of isoniazid and the potentially adverse events. Carbamazepine, which is another anticonvulsant medication, also meanwhile can induce or increase the metabolism of by isoniazid. So therefore, it decreases the efficacy now of that anticonvulsant medication. And the most common and serious adverse effect of isoniazid would be hepatitis. Um, it can range from mild liver enzyme elevation to severe hepatitis. So it can even present as a hepatic necrosis in histopathologic cases. So that could lead to end-stage liver disease. So the risk is usually higher among elder patients and those with heavy alcoholic intake. If it is just a mild elevation of the liver enzymes such as AST and ALT, so there's no need to discontinue the drug. But if there are symptoms and there are other laboratory findings or clinical findings that would point to liver dysfunction, it's best to temporarily discontinue the medication and later on try to determine if there's still the need to continue isoniazid. Another important adverse event would be peripheral neuropathy because especially in patients with pre-existing vitamin B6 deficiency, because isoniazid induces excretion of pyridoxine. And this is more likely among those with the slow acetylators, which I mentioned earlier in terms of a particular type of metabolic activity in isoniazid. So this is usually common if the isoniazid dose is more than what is recommended, which is more than 5 milligram per kilogram per day. So it's very important for these patients to be given vitamin B6 supplementation. So if you're giving COX regimen with isoniazid, you should also supplement the patient with vitamin B complex. Hypersensitivity reactions are common, and there are also neurologic symptoms that might affect the central nervous system, such as memory loss, ataxia, psychosis, and seizures. Rifampicin, meanwhile, is a semisynthetic antibiotic produced by Amycolaptosis rifamycinica. So it binds to the beta subunit of the bacterial RNA polymerase, which is a key enzyme in the bacterial protein synthesis. Therefore, it prevents the growth and replication of the bacillus, so which the one that causes the disease. It is a drug that is well absorbed orally, and its peak plasma concentration happens in 3 to 4 hours. It has a high protein binding, about 80%, but it can also cross the blood-brain barrier, or the BBB. Its main metabolism is through the liver by deacylation with the help of the cytochrome P450 enzymes. It's primarily excreted in the bile and then eventually through the feces. 30%, so so 3/10, so a minority is excreted in the urine. Its half-life would vary per individual, but it's usually on the average about 2 to 4 hours. It has a bactericidal activity. There could be also resistance to this drug, especially if there's point mutations in the RPOB gene, which is the gene for the beta subunit that I've mentioned here, which is the focal point of this antimicrobial agent. So it reduces because of that mutation, it reduces the binding of the drug to that beta subunit. So therefore, it cannot exert its effect in inhibiting RNA synthesis. Again, because of its drug interactions, it induces most common cytochrome P450 isoforms such as CYP1A2, 2C9, 3A4, 2D6. So increasing the elimination of numerous drugs such as anticoagulants, cyclosporine, protease inhibitors, contraceptives. So um, so some of the most important drug-drug interactions, like again the oral contraceptives, it can decrease the effectiveness of oral contraceptives. So this is especially significant among women of reproductive age. Anticoagulants can also its effect can also be lowered down by rifampicin because of the increased stimulation of the cytochrome P450. And in patients now with HIV taking antiretroviral medications, so it can decrease the blood levels of certain medications, yung mga protease inhibitors and the non-nucleoside reverse transcriptase inhibitors. So because pulmonary tuberculosis also has a high infection prevalence in people living with HIV. The most common adverse event, quote unquote, but not really that adverse, would be yung orange discoloration of your urine. This is a relatively benign finding, and you don't need to discontinue the drug because of that. But the most serious adverse effect would be hepatotoxicity. Again, it could be as simple or as mild as elevation of the enzymes, but it could also lead to severe hepatitis. It could lead to also to cholestatic jaundice. There's also skin reactions, flu-like symptoms that could happen, presenting with fever, chills, and muscle aches. And there could also be hematologic changes, no, such as lowering down the platelet count or thrombocytopenia. Ethambutol, meanwhile, is a synthetic antibiotic that works by inhibiting the synthesis of arabinogalactan, which is a component of the mycobacterium cell wall. It disrupts the cell wall, which leads to the bacterial cell death. Okay, so it inhibits this arabinosyl transferase 3 enzyme, disrupting the transport of the arabinose, which is a type of sugar. So therefore, the biosynthesis of that galactan disrupts the formation of the cell wall. And resistance, no, for this antibiotic is due to the mutation in the codon of the EMB gene, as you can see here. So it's bacteriostatic, not bactericidal, unlike the other anti-TB drugs that I've already mentioned. It has a good absorption also with the peak concentration in 2 to 4 hours with lower protein binding. Its main metabolism is again in the liver, but it's primarily excreted unchanged in the urine, and 20% would be through the feces. The half-life is also 2 to 4 hours. It could cross in the blood-brain barrier, particularly if there's presence of inflammation, no, of the meninges. So the most common serious event would be the optic neuritis or the retrobulbar neuritis, which can lead to blurring of vision or even loss of vision. But this is usually common, no, if the dose is more than 25 milligram per kilogram per day. So therefore, it's very important to do regular eye examinations or even a baseline or initial eye examination prior to giving ethambutol. Gastrointestinal adverse events, nausea, vomiting, diarrhea, abdominal pain can happen, and also arthralgia or joint pains can happen in patients taking ethambutol. Pyrazinamide, meanwhile, is a synthetic antibiotic that works by disrupting the bacterial cell wall of the bacilli. It is a drug converted to pyrazinoic acid, the active form of the drug, by a mycobacterial pyrazinamidase, okay, which is encoded by PNCA, as you can see here in this figure. So the pyrazinoic acid disrupts the mycobacterial cell membrane metabolism and transport function. So As you can see here, there's acidification of the cytoplasm, which leads to the disruption of the membrane function, inhibition of the fatty acid synthase 1, which is a building block of the bacterial cell wall. Um, and there's also the metabolism changes now in the NAD, which is a very important electron transport system in order to have a efficient cellular function within the bacilli. Um, it is a relative of nicotinamide, slightly water soluble. It has a good oral absorption, and its peak concentrations occur 1 to 2 hours after intake. Um, it's metabolized both in the liver and the kidneys. It's also a bactericidal agent, but it should be at a higher pH levels. It has limited drug interactions as compared to the other first-line anti-TB meds. The most serious adverse event, again, here would be hepatotoxicity. There could be also joint pains, and a very unique adverse event here would be hyperuricemia, which can lead to gout in certain individuals, and photosensitivity as well. Okay, so streptomycin, meanwhile, okay, so this is the only parenteral agent in the first line anti-TB meds. It's an aminoglycoside that works by binding to the bacterial ribosome and interferes with the protein synthesis. So it binds to the 16S RNA of the 30S subunits of the ribosome. So it definitely is inhibits the eventual protein synthesis of the microorganism, leading to bacterial cell death. It is poorly absorbed from the GI tract, so therefore it's parenterally given. It has a good volume of distribution. It can also cross the blood-brain barrier. It's primarily metabolized and excreted in the urine. So therefore um, the dosage of this medication is adjusted depending on the individual's renal function. So it's very important also to have a baseline liver and renal and kidney function by getting the liver enzymes and the BUN and creatinine of these individuals prior to starting the treatment. It has drug-drug interactions with NSAIDs, so it can increase the risk of nephrotoxicity. And then you should also be cautious if this patient takes a loop diuretic like furosemide, because it can increase the risk of ototoxicity. If these individuals have loop diuretics and also being given streptomycin. The most serious adverse event would be that one, ototoxicity, that could lead to hearing loss or worse, deafness. So hearing tests are recommended even at baseline also before starting streptomycin. Now, there will be instances that second-line drugs would be the only option, because sometimes there is resistance, because there are various mechanisms that I mentioned that could lead to the resistance of the first-line anti-TB medications. So culture studies are performed depending on the clinical scenario, particularly in patients that did not have a good clinical response or a microbial elimination of tuberculosis after months of the anti-COX treatment. So it could be monoresistant, meaning there's only resistance to one anti-TB drug, but it could be more than one, or polydrug resistant. Multi-drug resistant specifically talks about resistance to isoniazid and rifampicin. And then a very worrisome trend is now the occurrence of extensive drug-resistant TB, or the XDR-TB, because now even with the injectable medications, there is resistance, no? by the individual using the culture studies. And then a very important diagnostic tool that has become available would be the detection of resistance to rifampicin using a gene expert, or what you call the MTB RIF test, uh, which would be helpful. No? It's the results are much faster. Um, the demand of getting the sputum test as compared to the acid fast bacilli testing would be less strenuous and less demanding. So gene experts have become an important diagnostic in detecting the presence, no, of pulmonary tuberculosis. So what are some of these second line medications? So the first one would be this one, the fluoroquinolones. It works again by inhibiting the DNA gyrase and topoisomerase 4, which are enzymes, no, for bacterial DNA replication. So therefore, it prevents also bacterial growth and replication. So they would say that the moxifloxacin would be the most active against the Mycobacterium tuberculosis, and then followed by levofloxacin, then ciprofloxacin. But for atypical Mycobacterium, ciprofloxacin is said to be more effective among the fluoroquinolones. It is also generally well absorbed from the GI tract. So these are oral medications. It has a good volume of distribution. It's metabolized by the liver, and it primarily excreted in the urine. So resistance can develop also because there's a tendency of use of fluoroquinolones, particularly in other respiratory tract infections and urinary tract infections, and also in skin and soft tissue infections as well. So there's also now increasing resistance, no, to fluoroquinolones. So these four are the also locally available fluoroquinolones in the market. Some of the problems that could happen, particularly in fluoroquinolones, would be increasing the QT interval, okay, which is a heart rhythm abnormality, especially if the patient's been taking antiarrhythmic medications, antidepressants, or even antipsychotics. And then iron supplements can reduce the absorption of fluoroquinolones and also antacids as well. So the efficacy of these medications may be hampered, no, if the patients are taking these medications. In terms of adverse events, gastrointestinal, central nervous system, and I mentioned the cardiovascular system adverse events here. Okay, so those are some of the features. They could also increase the risk of tendinitis and tendon rupture, especially in older adults or patients with certain underlying conditions. Kanamycin, meanwhile, is again, like streptomycin, is an aminoglycoside antibiotic binding to the ribosome. So again, in the 16S RNA of the 30S subunit of ribosomes. So again, like streptomycin, it has poor oral bioavailability, so it's given intravenously or intramuscularly. It has a low protein binding activity, just 10%. It's also needed to be adjusted, no, in terms of its kidney function, because there are instances that it's primarily and all of the metabolites are excreted in the urine. And similar to streptomycin, ototoxicity and nephrotoxicity are the common adverse events, no, of these medications. The half-life is usually 2 to 3 hours, but definitely it's longer in patients with chronic kidney disease or renal insufficiency. Concurrent use of NSAIDs can also increase the risk of nephrotoxicities, similar to streptomycin, and also with the loop diuretics as well. Amikacin, again, another aminoglycoside. So again, same mechanism of action here. Again, poor bioavailability. Peak serum concentration is much faster, about 30 to 60 minutes. Again, there's renal dose adjustment. Ototoxicity and nephrotoxicity, again, are the most common adverse event, and drug-drug interaction of NSAIDs and loop diuretics also is applicable here. But a very unique adverse event here would be yung acute muscular paralysis, no? Because it could cause neuromuscular blockade and respiratory depression. It can also increase risk, no, of sleep apnea, no? Especially if the individual has, no, the risk factors for sleep apnea, such as those individuals with obesity. Linezolid is a oxazolinidone type of antibiotic. So it binds to a different area of the ribosome, which is the 23S RNA of the 50S subunit. Therefore, it blocks the translation of the protein, leading to the bacterial cell death. So it's available in oral and parenteral forms. It has almost 100% bioavailability. Peak serum concentrations is relatively quick, no? Around 1 to 3 hours. It is converted to inactive metabolites and by the liver, and it's primarily excreted in the urine. The half-life is usually around 5 to 7 hours for linezolid. It has a good bactericidal activity. Its common adverse event would be what you call the serotonin syndrome, no? When used in combination with other drugs that can increase serotonin levels, such as tricyclic antidepressants, monoamine oxidase inhibitors. So these are antipsychotic medications, particularly for mood disorders. Linezolid can also increase the anticoagulant effects of warfarin, increasing the risk of bleeding. On top of that, it can also lead on its own the decrease in production of the platelets, leading to thrombocytopenia. And it could also lead to gastrointestinal symptoms, which is usually the most common and relatively mild, no, in its manifestation. Cycloserine is a organo-oxygen heterocyclic antibiotic, which is an analog of D-alanine. So this is also isolated from another microbial organism, which is a Streptomyces. It interferes with the enzymes involved in the formation of the D-alanine. So it inhibits these two enzymes here. So therefore, it affects again the cell wall and leading to disruption and bacterial cell death. It's bacteriostatic, not bactericidal. It has a good bioavailability, 70 to 90%. It's primarily metabolized again in the liver and excreted primarily in the urine, with a half-life of around 6 to 8 hours. In terms of drug-drug interactions, again, anticonvulsant medications are involved here because this medication can increase the blood levels of those medications. So there could be the adverse events related to the anticonvulsants that can occur, no, with the individuals taking this medication. There are CNS manifestations that could happen, ranging from mood disorders such as anxiety or and even neuromuscular, no, such as presence of tremor or seizures. It can also transiently increase the liver enzymes, the SGPT, SGOT, and can also, since it's metabolized in the kidney, it can also lead to acute kidney injury. Clofazimine, okay, a different group of antibiotic, which is also inhibits the synthesis of bacterial cell walls. So it also interferes with the protein synthesis by binding to the guanine bases of the bacterial DNA. It is slowly absorbed from the gastrointestinal tract, but still yung peak serum concentration nito is a bit slower as compared to the anti-TB drugs, which is around 8 to 10 hours. It has a wide distribution throughout the body. It accumulates in tissues with high lipid content, such as skin, liver, and the adipose tissues. Bioavailability has a wide variance among individuals. It's primarily metabolized in the liver and primarily excreted in the feces, not in the urine. Um, a common event, adverse event that is related to clofazimine is um, the discoloration of the skin and the conjunctiva to become red or brown. But this is reversible when the drug is discontinued or not taken after a few weeks. Gastrointestinal symptoms are also common: constipation, diarrhea, heartburn, abdominal pain. Um, Blurry vision, dry mouth, increased thirst, and urination are some also of the common adverse events associated with this medication. And then dapsone is this is a drug that is given in leprosy. So which is a disease caused by Mycobacterium leprae. So it's also a good agent for mycobacteria, but more for the leprosy, not pulmonary tuberculosis. But it's also given, no, as an alternative, no, in case of adverse events associated with the second line or first line medications or other contraindications. So it inhibits the synthesis of the bacterial diaminopimelic acid, which is also part of the cell wall. So it competes with the para-aminobenzoic acid. So again, it competes for that enzyme here, the dihydroterotate synthase. So it has a good bioavailability, so it's taken orally also. It's metabolized in the liver through the cytochrome P450 system. It is it has a good peak plasma concentration at around 2 to 4 hours. The half-life varies, no? It's much longer. It could range from 24 to 36 hours. Um, it also has significant drug-drug interactions with the antiretroviral medication. So it's very important, especially in patients with HIV, taking antiretroviral medications, because toxicity might be increased, no, if taken concurrently with this drug. It has skin reactions. Caution is also given, especially in patients with the G6PD, the glucose 6-phosphate dehydrogenase deficiency, because it can lead to hemolytic reaction, increasing the breakdown of the red blood cells that could lead to anemia and potentially fatal complications. So it's very important to give also a vitamin B supplementation in patients taking dapsone. Next one would be prothionamide, which inhibits the synthesis of mycolic acids. It's also well absorbed from the GI tract, good bioavailability of 90%, primarily metabolized in the liver, primarily excreted in the urine, with the peak serum concentration of 8 hours and the half-life of relatively the same time, 8 hours. It's also bactericidal activity, and it also has significant drug-drug interactions with anticonvulsant medications that could lead to depression, hallucinations, and peripheral neuropathy. Hematological signs can also happen, such as anemia and thrombocytopenia. And hypothyroidism is a very unique adverse event associated with this medication. But prothioamide is not being used, no, in high frequencies, at least in the local setting. Finally, there's also the carbapenems, no, which are the beta-lactamase, so relatives of the penicillins. Again, they're not used for first-line medications. They could be used for multi-drug resistant or extensively drug resistant, or the XDR-TBs. It has a direct antimicrobacterial effect. So it exerts immunomodulation by increasing the reactive oxygen species, activates the P38. There's an increase in pro-inflammatory cytokines and co-stimulatory um, molecules, which would activate the macrophages. There's an increase in M1 macrophages. And then this innate immune modulation would now lead to the modulation of the adaptive immune responses, increasing the T cell activation, the differentiation of the T helper cells, and enhanced T cell memory responses. So there, therefore, it's exerting its antimicrobacterial effect, and would eliminate the presence of that organism in the body. So these medications, unfortunately, are parenteral and usually given intravenously. So it's relatively very impractical, especially if you're thinking of long-term treatment, since it takes months to treat tuberculosis. So carbapenems are usually reserved as a very severe or extreme alternative in treating pulmonary tuberculosis. So again, going back, no? So there are the minor adverse events. So what you need to do. So for example, so GI intolerance would be a good example, slight epigastric pain or nausea and vomiting. So what you can initially advise is you can tell them to give the drugs at bedtime or with meals, because usually the anti-COX medications are given before meals, usually in the morning. No? So sometimes you can give it also at night or after taking meals. Um, Hypersensitivity reaction is a very common adverse event, not just for anti-TB drugs, but to other medications as well. If it's mild, you can take antihistamines, but for severe hypersensitivity or presence of Stevens-Johnson syndrome, that might require discontinuation of the medication. There could also be dose adjustment, no? Or you can do dose challenge also if the hypersensitivity reaction is not that severe, and you want to later on continue the medication when the rashes or the hypersensitivity reaction have subsided. Again, rifampicin is associated with the orange discoloration of the urine, so you just have to reassure the patient. Peripheral neuropathy presenting with burning sensation in feet, usually caused by isoniazid. You need to give vitamin B6 supplementation. Joint pains due to pyrazinamide, you can give usually NSAID, but again, it might interfere especially with the aminoglycoside antibiotics. So you have to be very wary, and you have to measure also the serum uric acid, because it might already be a gouty type of arthritis that's happening in the patient. And if it's elevated, you have to give medication to lower down serum uric acid levels. But the major adverse events now would entail discontinuation of these medications. No? So as you can see here, yung hepatotoxicity with jaundice is usually implicated to either isoniazid, rifampicin, or pyrazinamide. Psychosis or convulsion due to isoniazid, hematologic reactions would also need discontinuation of the drug. Usually it's due to rifampicin. Nephrotoxicity, such as decrease in urine output or proteinuria, you might as well refer it to me. So in patients with mild allergic or hypersensitivity reactions, you might possibly resume those medications. It's usually the ethambutol and streptomycin that would have the most likely cause. So if you would again resume those medications, you would start with either the isoniazid or rifampicin because usually they're the less frequent causes of hypersensitivity reactions. And then you gradually increase the dose. Okay. Usually, the anti-COX medication, particularly the first line, is given as a fixed drug combination, meaning in one tablet, uh, it already contained the isoniazid, rifampicin, pyrazinamide, and ethambutol. This is so because this would increase the chances of compliance. Because if you would give these anti-TB medications individually, separately, the pill burden would be high. So usually, for example, for a 60-kilogram individual, you would give 4 tablets of this fixed drug combination of anti-TB drugs. But if you would give this individually, like isoniazid tablets, rifampicin tablets, ethambutol and pyrazinamide tablets, it could be more than 10 tablets per day. And that would be very difficult. And as as I've discussed earlier, the duration of the medication is at least half a year, no? Especially for new cases. So it would be very difficult. That's why fixed drug combination helps. But in giving the challenge dose, you have no choice but to give those anti-TB drugs again individually. Streptomycin is given parenterally, so it's a different story altogether. If you would compare it with the oral anti-TB meds. So monitoring the treatment is very important. Again, for those new cases or the category 1 or the extrapulmonary TB except the CNS and the musculoskeletal. So you should do a repeat sputum microscopy after the second month. That's the end of the intensive phase, the end of the 5th month, and the end of the treatment. So it depends, no? Usually after 6 months. Depending now if the sputum is still positive at 3rd month, so you might need to do further testing for the possibility of a multi-drug or extended drug resistance. But if there is if the sputum microscopy is negative, you just continue the medications and hopefully that would persist until the treatment is completed. Again, these are some of the scenarios depending if the sputum still remain positive, no, at the end of the 5th month or even at the end of the treatment. So you have to consider for multi-drug or extended drug resistance. And then for category 2, so again, the repeat sputum microscopy would be given at the end of intensive phase after 5 months and when the treatment is completed. So if it persists as a positive finding, again, refer to a facility which would determine the presence of resistance, no, to a particular anti-COX medication. But if there's already a negative result, no, of those sputum microscopy, just continue the medications and hopefully it would signify the clearing, no, of the mycobacterium in the individual's body. So depending now on the clinical evaluation and the microbial analysis after the treatment is completed, so the patient can be either be cured, completed treatment, failed treatment. We want to avoid patients dying because of TB, but remember, we have a very high mortality rate. 4 individuals per hour die of tuberculosis, which is somewhat more devastating than the COVID. So it's very important to label these patients. It's very important their outcomes. It's very important to emphasize compliance with these medications since it's relatively easy, no? Yung direct observed treatment short course, so which will be further discussed, no, when you have your lecture on pulmonary tuberculosis. So there's still the challenge of treatment of the tuberculosis, but it is still treatable in a very large percentage of individuals, especially among new cases. It's just very important, again, to educate the patients, educate on minimizing the stigma associated with pulmonary tuberculosis, the misconceptions, um, and I'll also definitely advise the patients on the most common adverse events and what they can initially do. Or you can either reassure also the patient that those um side effects are relatively mild and they won't have any significant impact of causing any bodily harm in the patient. So with that, thank you for listening and have a good day.